Ellen, what are your selection criteria as you think about higher risk MDS patients and whether you're going to recommend a hypomethylating agent versus recommend that those patients go to transplant?
It depends on a lot of factors. I mean, again, getting to know the patient and what their goals are, I think, is a very important part of the initial discussion. I agree with you very much that a person who goes forward to transplant, who's an elderly person, it may be 2 to 3 years out of their life before they are at the functional level that they were prior to going into transplant. And that's a very hard thing to understand, actually, for a lot of people. So a lot of discussion has to go forward, talking about the risks and benefits of that period of time of convalescence, really. I also look very closely at the functional status of the patient, the caregiving situation of the patient, and whether or not they have comorbid illness. I actually look at the caregiver very, very carefully because an older patient who has a spouse who's ailing does not really have a good caregiver. There's going to have to be a child nearby who's willing to take on that role. That they have a friend in the neighborhood is not going to be enough, actually, to get them through a transplant. So family support or patient support is critically important, I think, for an older patient that goes to transplant, and it's really an area which has not been carefully looked at. If your job is to take care of your demented spouse, that's not going to be a good transplant candidate. So really understanding what their caregiver situation is. It can be very murky looking at comorbid illnesses in older patients. Guy smoked for 50 years. He still plays tennis, 3 times a week. He's got good muscle mass. He has no other real comorbid illness. Still, those are a little shaky. Those patients can have problems during transplant. So I think it's very difficult to tease out those patients who are going to do better or worse than transplant. I have been surprised by patients of mine who have had multiple comorbid illnesses who've managed to get through transplant rather unscathed, and patients who were playing 6 sets of tennis, every single week who had a really difficult time during the transplant convalescence.
So I'll ask a controversial question. We don't have the answer to this yet, and there's a study in Europe that's trying to address this, and then there's a study in the US, the Clinical Trials Network, CTN 1102. We have a patient with higher risk MDS. Do you send that patient immediately to transplant, or do you treat them with hypomethylating agents first, or do you give them AML type induction therapy first to try to get them in remission before that transplant?
Right, so it is a very controversial question, and I think you get different answers on this. So two things. I think one question you are posing again is like almost the timing of a transplant in a higher risk disease. I think our practice still we send them to transplant immediately, but every now and then you see those patients that had a complete response on hypomethylating agents, and you start like doubting in your mind, should I wait on the transplant till the response is lost? And I think that's a reasonable discussion with the patient, because we know that if patient is in complete response with hypomethylating agents, they are driving more benefit than the average patients. And you could say, well, let's wait with the time of the failure of the therapy, with the caveat that at that time, if the disease is in AML, which 1/3 of the patients could go there at time of failure, then you do induction. So I think it's reasonable in a subset of patients if you started hypomethylators and they have a very good response, they are in their 70s, not that young patient, to discuss that. The question to start a treatment before transplant or not, I think also is challenging is like, what's the goal? So as I mentioned, like we actually end starting in many patients, if they are symptomatic, most of them are cytopenic. And with the rationale that even when you send patients to transplant, many of them are not gonna get transplanted. When you start hypomethylating agents, you are starting a definitive therapy for their disease. And whether a response prior to transplant or not makes a difference in the outcome of transplant, that's also a very controversial issue. We know that hypomethylators are probably as good as intensive chemotherapy in majority of patients. The French had published study looking at azacitidine versus intensive chemotherapy prior to transplant. We don't know whether a response, like a complete response or a cytogenetic response matters. In the past, many of the studies were based on chemotherapy and showed that chemo or no chemo, there was no difference. They were all retrospective. In my opinion, they were a little biased. Patient that had higher blasts got chemo, patient that had lower blasts did not. In patients that get chemo, if they achieve a CR, they did better with transplant. I try not to do intensive chemotherapy as much as I can, so if I go with hypomethylating agents, for the reasons I mentioned, I do think that we need to show if there is a response prior to transplant that matters, that we may need to rethink of that strategy, but hopefully this answers the question.
I wonder if, I mean, there's probably no answer to that unless you do randomized trials, but I think I tend to do the same. I'd rather start with the hypomethylator because I still feel like I have one other option to go to. Should this disease prove proliferative, then at least I may fall on induction chemotherapy if this is a transplant candidate. But clearly there's no trials to support this kind of an approach, but maybe the ones that you've mentioned will give us a signal one way or the other.
I think our approach is similar, and for the reasons you've both elucidated. For younger patients with higher blast percentages, so 17, 18%, where maybe if you had moved the bone marrow biopsy needle 1 millimeter over, it would have been 21%. Those folks we will take through induction chemotherapy as if they had leukemia, because even though they have MDS, the remission rates for those patients are still 40%, right? Which is the highest remission. You're much higher than you're going to get with a hypomethylating agent. For older adults or those who have lower blast percentage, and we can define lower however we want, probably up to 10 or 12%, those folks we will take through hypomethylating agents, particularly because you don't know if the transplant's going to happen. And I think that was a critical point, right? For all these folks we refer to transplant, we know how many actually make it through, right? 50%, as you mentioned. So for the 50% who don't make it to that transplant, we don't want them sitting on their ducks waiting for something that's never going to happen.